Good evening, everybody. Happy Tuesday. Happy St. Patrick's Day. I guess I should have worn some green. Here, let's change. Let's make our lights green. There we go. There's my St. Patrick's Day celebration. My St. Patrick's Day green. How's everybody been? If I can get some thumbs up, some likes here, just to make sure everything sounds okay, looks okay. Perfect. All right. You all know the drill. Here to chat weekly, answer any questions you all have. We will dive into, if you want to throw some questions in here, I've got some stuff prepared this time. I was able to take some time and go through and look at these questions, make sure I was prepared to kind of go through and talk about with specific footage and stuff. So we will go through these. If you all have any more questions and you want to go throw them over on the channel page, then down here, down there, yeah, down there, be sure to go do that, and we will get to those. As always, if you want to ask some questions directly in the chat over here, then be sure and join. We still have the Discord up too, right? And nobody's really talked about that much or said much in it, but I still check it. So if you want to still have the benefit of joining the channel membership and go talk over in the Discord, ask some more questions, I am here for you all. And so, yeah, here for you all. Ask questions away. We will dive into some stuff here. Thank you. Appreciate it. All right, let's see. The Kent Tekulve pitching style lead to more injuries? If so, what ones and how so? I'm going to be honest. I'm going to show my lack of baseball knowledge. I'm not sure what you all mean by this Kent Tekulve pitching style. Let's see what I can find. Pitching style. I'm doing excellent. Good evening. Good evening. Oh, okay. So he was just like a sidearm. He was just a sidearm pitcher, right? Is that kind of the gist of this? Yeah. Yeah, cool. So he was just a sidearm pitcher. Kent Tekulve. I'll be honest, I don't know of any exact literature that has looked at this. So I'm not sure. I think just in general, right? I mean, I think the biggest thing that's influencing elbow injuries is just the push for speed, not so much specific mechanics. Like, guys can deliver effective pitches with a pretty wide variety of throwing mechanics. And so I think it's probably, this is again, me not having dove super deep into the literature on this. I think it's more just your pitching speed than it is necessarily the exact way that you throw. Like, a lot of people just have a different, like, kind of preference with their arm slot, right? And so I don't think there's enough pitchers that throw that way to specifically make a big statement about it, right? Like, you've got such a small percentage of pitchers that are throwing like this submarine kind of style, or kind of sidearm style. And so I think it's probably harder to make a big, strong statement when it's just a small percentage of people that are throwing that way compared to everybody else. So, yeah, it's a good question. Maybe I'll put that on the list to try to find some exact research. Or if you've got any that you know about, I'd be curious to hear more about it. Thumbs down. I love when I get thumbs down for doing... It's fun. I can see those come through. It's always great to get thumbs down for doing a live stream. All right, let's see. Excellent. Thank you for joining, becoming a member. As always, ask questions. Like, I'm here for questions for you all. So feel free, Blee3E, to ask away, and we will get to any of your questions. Yeah, we'll come back to some Lindsey Vonn stuff. Yeah, really sidearm. Jalen just had surgery. ACL surgery. Well, shoot. How did it happen? What'd you do? If you don't mind me asking. And any other, like, meniscus, MCL, anything like that? Curious. Let's see if I get any more info from Jalen here. While he's waiting to chat to type that in, let's see. We're just going to go in order of things. March Madness. Yeah, I'm a Kentucky fan. I'm a Kentucky basketball fan, but I'll be honest, I haven't really watched much this past year. So I'll watch, but I don't get too into it. All right, let's go through questions. Older topic, Lindsey Vaughn said you still would have cleared her since she's an adult and knows the risk. Is there a scenario that you wouldn't clear an adult for a return to sport? Yeah. Things that are clearly going to be, things that are clearly going to be like cardiac, maybe fatal, right? If you've got, and I'm not a cardiologist, so I'm not in that position. And if I've got an older athlete, right, that wants, clearance to do like a marathon or a triathlon, and they've got some extensive cardiac history and they're asking for my advice, right? I'm probably going to involve a cardiologist to ask about that and make that decision. The hard part is there's not for a lot of those situations, there's not necessarily like a hard, fast medical clearance, right? Like if you're just going to go sign up for your local 5K or your local triathlon, there's not necessarily like a sports participation, like physical that you have to go through, right? There's going to be some sort of like clearance, like you're going to sign a waiver that's like, I'm not going to hold the event liable if I have a heart attack. But it's not like you've got to get permission as an adult to go through and do something like a marathon or triathlon. Now, if you're competing for, let's say, you're a NFL athlete, right? You've got your team that has to clear you. And so, yeah, there would certainly be situations, concussions that are not fully recovered, severe spine injuries. There are some conditions where people can get like congenital narrowing of the spine where they're at very high risk of paralysis if they have multiple repetitive injuries that result in like a bilateral stinger type of phenomenon. And so, yeah, typically it's going to be like nerve problems. It's going to be more medical problems, brain problems than just like a musculoskeletal thing. And so, yeah, I mean, I think the big thing that with Lindsey Vaughn that makes me say I would have allowed her, and again, like, does she need my permission, is the functional stuff that we saw her do, right? The fact that she was able to go through and do like box jumps and squats and all this crazy stuff she was able to functionally do was what was so reassuring. So if she hadn't been able to do any of that, then I'd have counseled her like, no, this doesn't make sense. Like, you can't hardly walk or squat. What makes you think you're going to go down a hill? But she could do everything, like, right? They could progressively advance her up. So it just depends, right? And at the end of the day, I think my role with all that is helping with shared decision making. And so you give the information, you kind of try to counsel on the risks with everything, and then see where you go. We will get to this question. Don't worry, we're just going to go through in order here. Can you explain Tommy John injuries and surgeries? My favorite pitcher, Walker Buehler, was never the same. It's interesting but sad stuff. Yeah, so let's go over here and take a look at those. I've done some videos if you want kind of some additional information. We have certainly gone through and done some videos on that topic about specific players. So let's move this over. So UCL, Tommy John injury. So the UCL, the ulnar collateral ligament of the elbow, it's a passive stabilizer for the elbow. So on the inner side, this is the medial side of the elbow. So as you're holding up right here, this is the medial inner side, lateral's outside. There's this ligament called the ulnar collateral ligament. Ulnar because it's on the inside, the ulnar side. There's 3 bundles to it. This bundle here, this anterior bundle, is typically the one that's going to get injured. Let me bring up my mouse here so I can draw. So that's going to be the main one that's oftentimes injured. Treatment of it depends on tear location, tear extent, and what sport. So if you have a proximal tear, meaning up at this portion of the origin. So when we talk about like medical terms, proximal means it's closer to the body. Distal means it's further away. So as you go down the arm, you're getting more and more distal. As you come up, you're getting proximal. So this proximal portion of the ligament has better blood supply, tends to heal better with conservative treatment. Distal down here, not as great a blood supply, tends to be less optimal outcomes when it comes to success of conservative treatment. So what you do about it depends on your sport. If you are a high-level elite baseball pitcher who has a higher grade partial tear or a full tear, you're probably going to have Tommy John surgery. Just simpler, get it done, move on. If you're a non-overhead athlete, like let's say you're a wrestler, even if you have a complete tear of that ligament, you don't need to do surgery. So it depends just as much on what you're doing for your sport as what the pathology looks like. I had a basketball player who I treated recently, played football, played basketball, dislocated their elbow. and had a complete tear of these ligaments and did great. Like, his back playing sports, no issues, no problems, doing fantastic. Now, if that was an overhead throwing athlete, be a different situation. You'd probably be doing surgery to repair it. So treatment of it depends on location. It depends on sport. It even depends on position. If you're an infielder versus a pitcher, catcher, you're going to have a different threshold for doing surgery or not doing surgery, and also time of the year, because this is going to be a year, 12, 15-month recovery. And so if it doesn't matter if you're going to miss the upcoming season or not, you might give them a chance to heal conservative, something like a PRP injection. Otherwise, you're going to shut them down and do surgery right away. So that's kind of some basics about it, to hopefully answer some questions there. All right, let's go back to this one. All right, how would you approach Achilles tendinitis for a tennis player? What type of preventative measures so it doesn't rupture? So I don't think I would treat it any differently for a tennis player versus any other athlete. Number one, I think you've got to monitor pain. So the first stage for me when I'm treating any sort of tendinitis is like, what's the level of discomfort? Is there severe pain, severe discomfort that's limiting activity where we need to back off on the loading? If pain is under fairly good control, right? People can tolerate some loading. Tendon cells respond to load. The tenocytes are the cells inside of a tendon, and those tendon cells respond to load. They respond to exercise. They respond to mechanical loading. And so that's why everybody stresses the importance of physical therapy when you have a tendon injury. It's not because we're just like saying, go stretch and like you'll feel great. It's because we know that progressively loading tendons stimulates tendons to heal and to become stronger, more resilient to future injury. And so the most important part, like long-term treating Achilles tendonitis, any tendonitis, is to have some degree of like progressive loading. I kind of see that as like the foundation for what you need to do. Everything then you layer on top of that is how you try to help with pain, how do you try to promote that healing with additional measures, things like nitroglycerin patches to help with pain, medications, PRP injections to help promote pain and healing, stuff like shockwave, things that PTs can do with scraping, dry needling, etc. All that stuff kind of layers on top of it, depending on the individual preference, depending on resources, to try and promote additional healing and help with pain. There are some, right, like if some teams have tried to look at doing like preseason ultrasound scans of Achilles tendons to look at like rupture risk. I don't think any of that has really played out great, because a lot of people will have like abnormal tendons on imaging, but not necessarily like a problem, right? So just because you see some imaging evidence of tendinitis doesn't mean you've got a problem and you need to like shut down and treat it. It really depends on the symptoms and the level of pain. So most important part, you've got to do some degree of loading as pain is improved. You've got to progressively load tendons. Tendons want to be loaded, but they need to be loaded in the right way. So that's why when we say go to physical therapy, that's what we're really trying to involve. So that's the most important part. Layer on your modalities, layer on your pain control things as your resources allow, depending on what you have available to you: PRP, shockwave, nitroglycerin patches, medications, equipment stuff like a heel wedge that tries to offload the stress a little bit of the tendon. I don't generally immobilize. I don't generally put people in boots because I think that shuts you down, causes more stiffness, atrophy, etc. Favorite sport? Golf, to be honest. Favorite sport to watch? Football. Like NFL football, favorite sport to watch. My favorite sport to play when I was younger was basketball, and then I played tennis. Tennis was my main sport in high school. Currently though, like just to follow, like I golf myself. And so when you get older and you start having other injuries, and I'm worried about rupturing my own Achilles and ACL and stuff, golf is kind of where I'm staying and where I'm steady. Appreciate it. Compound fracture while playing pickup basketball. Aside from calling 911, should I cover it up with something, or is there a risk or infection for doing so? Yeah, I would cover it up. That's a great question. If you're somewhere and like you have somebody like, whoa, bone is like through the skin, what should you do? Just for the sake of like people around not freaking out and seeing it, like, yeah, kind of put something over it. Put something over it. Try to keep the person comfortable from like flailing around and like the limb flailing around and getting worse and getting more unstable. Like what the medical team is going to do, the paramedics are going to do, is they're going to try to splint it. So they're going to try to stabilize it as best as possible, put it in a rough aligned position, put some sort of splint around it. So try to keep the person calm and keep everybody around them calm. So yeah, covering it up. If it's compound the bones through the skin, they're going to wash it out. They're going to be on antibiotics. Don't worry about if you're, don't take some like dirty, wet, like nasty towel from the pickup game and like put it on. Try and get something clean, something as clean as possible to just cover it for the sake of like keeping everybody around it from seeing, oh my gosh, like a broken bone, just for like respect. It's not going to make a drastic difference of how it heals. So yeah, good things to be thinking about. Jalen basketball landed wrong. Bucket handle meniscus. Yeah, shoot. Hopefully they were able to get in there and fix it. Meniscus root tear. Let's talk about root tears real quick. That's something that we haven't really specifically talked about on the channel, but it's an important thing to discuss. So let's talk about meniscus root tears. Let's hide some stuff here. Let's get to our meniscus. I like golf. I don't like TGL though. I haven't really watched any of TGL stuff. I don't like it. But the players I probably watched. Oh goodness. I'll watch hours of Masters coverage. I watch golf most weekends. It's kind of my main sport. All right, meniscus root tears. Let's talk about them real quick here. So menisci, right? There's a lateral, there's a medial meniscus. Let's get rid of some of these little tendon sheaths and bursa and stuff that we don't care about. Okay, let me see that. Okay, meniscus. Yeah, perfect. So the menisci, right? Medial and lateral meniscus. Medial meniscus, lateral meniscus. If you look top down at the two menisci, the roots of the meniscus is where the meniscus is anchored into the bone, right? The meniscus has to attach somewhere. The meniscus has some meniscofemoral, meniscotibial ligaments that kind of help anchor it down into the bone, anchor it to the the overlying MCL. But the meniscus is also attached at this site here, the root, posterior anterior. Whenever you're squishing down the knee, right, you're pushing down that meniscus. When you push down, it wants to push out to the side, right? Like it wants to squeeze out like a jelly donut. And so you have to have that anchoring in place for it to maintain what's called the hoop stress. So whenever you push down, that imparts this hoop stress through the meniscus, which allows it to do its job in stabilizing and protecting the knee. When you have a root tear, which technically I believe is like within 1 centimeter of where it inserts, so about 1 centimeter, when you tear that root, you can lose the ability of the meniscus to maintain that hoop stress. So it doesn't want to stay fixed. It just wants to kind of like fall out to the side. And so a root tear is an extremely important tear to properly manage if you can repair it. Not all of them can or should be repaired. But trying to fix it to maintain the integrity, the stability of the meniscus so that it can do its job in trying to stabilize the joint, distribute forces through the knee. And so, right, if you look at our meniscus from the side, you've got your rounded femoral condyle coming in right here. If you didn't have this concavity of the meniscus, all of your force would be distributed through this little tiny focal point, right? And if you think about like pressure, right? A pressure is like a force per area. And so if your force is really high over a really, really small area, that's going to cause a higher contact pressure. And so you want to distribute that same force over a wider area, which is why your meniscus is in there. It's trying to distribute that force over a wider area and then help to also stabilize the joint. So that's a root tear. You may have not been caring about that, Senor Bentley. But there you go. That is a root tear. Let's see. Happened 2 weeks ago. Got an MRI. Found out it was torn completely. So yeah, basketball injury line. Be okay. Go home tomorrow. Interesting. They kept you overnight. Usually that's not a common, like most of the time it's an outpatient go home. So interesting, but yeah, no reason to question. Are artificial joints breaking down so much faster than real joints? Yeah, good question. Trying to depend on how I would describe or think about that. Well, I mean, for number one, like nothing is better designed than the human body. I mean, you look at all these like robotics companies, right? Like Optimus and everything. Like they're designing their robots like to mimic human anatomy, right? In terms of like, don't put the motors in the fingers, put the motors up in the forearm, and then big long kind of tendons to mimic down at the hand. And so I think true, like our body is just like what our body designs. It's just stronger, better. It's more equipped to handle the biologic like environment of our knee. But also too, right? You got to remember like our joints break down on a, not, maybe it's linear. I don't know how I would describe it, but it's not like it's good, then boom, suddenly it's bad, right? Your joint is changing through your entire life, and then eventually sort of gets to a point where it tips over and is painful enough and bothersome enough. But it's not like you just wake up one day with arthritis. Like arthritis is slowly developing over the span of your life. Like we all get arthritis. We're just not all affected by it the same way. But everybody has some degree of cartilage change in their joints as they age. We're all just on kind of a different timeline, right? Whether it's injuries, genetic, metabolic health, obesity, activity level, etc. But we think of like an artificial knee as like it's there and then it failed. Like it's a binary black and white thing. Our joints are still degrading, right? I mean, they're changing. It's not like they're breaking down. They're just changing over time with age. And so it's not like they're breaking down faster, one or the other. Yeah, interesting thing. Thoughts on the Rice method? Rice method. Let's kind of zoom out so people can still see this. I think it's fine. Everybody's like, I think some people are just kind of like trying to make a name for like their own stuff, and so this is like the hot thing to, it's like the hot thing to think about and like criticize and hate on. So Rice, rest, ice, compression, elevation. And the big thing that people hate on with Rice, the Rice method, is the ice part of things. Because there were some animal studies that showed that if you use too much cooling in ice, that you can maybe delay the physiologic response for tissue healing. Like those animal studies are fine. I'm not aware of any actual human studies that correlate with reduced outcomes or slower recovery or less functional recovery. It's purely based on like some animal research that shows that cold temperature can sometimes affect the physiologic like healing response. But how that translates to human injuries, we don't really know. My goal when somebody has a bad injury right away, like think of an ankle sprain, right? You sprain your ankle, it's big and puffy and swollen, you can't move it, it hurts like heck, you're miserable, the joint's stiff, the joint's tight, etc. The goal is to eventually get you moving. The goal is to eventually start that range of motion, start that proprioceptive training, start that movement, because again, that movement helps to improve healing of those tissues. Now, it doesn't mean like a grade 3 ankle sprain, go run on it day one. There's balance, right? Of how much you immobilize, get pain under control, and then as swelling is down, pain is down, you start to resume that rehab, that movement. I would rather somebody use ice on their ankle to help their pain than take a bunch of medications, right? I'd rather you use ice and get the swelling down than take a whole bunch of Advil or narcotics or whatever the case. And so I would much rather, I'm okay with the theoretical decrease in physiologic healing that we can't really quantify if it's going to help somebody's pain and it's going to help their swelling. Because getting your pain under control, getting swelling under control are the two most important steps initially with any sort of musculoskeletal joint injury. And if ice, compression, elevation are going to help do that, then go for it. I'd rather you do that than take a bunch of drugs. So yes, is there theoretically something there to where ice may be not great for healing? Sure. But like if we're talking about some fraction of a percentage, in the grand scheme of things, I'd rather do that than take a bunch of medicines to help with pain. And I don't want people to be miserable, right? You want to do something to help with their pain and discomfort so they can like function, work, go to school, etc. So those are my thoughts on the Rice method. Did an MRI on a 15-year-old with a lateral retinaculum tear on his knee. Never knew the knee had a retinaculum. Well, yeah, let's talk about that. Let's see. Oh, Jay, about your surgery, staying in the hospital. They want to make sure my leg didn't get air in my leg. If they did, I have to cut it open and let air out. I'm not sure what that means. I'm not a surgeon, though, so I don't know. Surely they had a good reason. Okay, did an MRI? Are you like a radiology tech or something here? MRI retinaculum tear on his knee. Didn't know the knee had a retinaculum. So the retinaculum is kind of just like this non-specific, like stabilizing soft tissue on the lateral side of the knee. So if we get rid of, these are kind of showing all of our layers, right? Bursa, tendon, If we zoom out a little bit here, some more bursa. Let's get rid of all this. Joint capsule, right? Kind of the lining that goes around the entirety of the joint. And then if you zoom down below that, you're going to eventually see your patella. And the patella sits in this little groove of the femur called the trochlea, kind of right back in through here. So the lateral retinaculum is just kind of this, oops, let me change to, just kind of this like some soft tissue that sits out here on the lateral side that is connecting between the patella and the lateral femur. I'm guessing it was a scenario of like a, I assume this is probably what they're talking about. I mean, the knee, right, could be a lot of things, but this is what I would assume it meant, is some of this kind of connective tissue between the patella and the femur. That would be my assumption. So sometimes I do like a lateral release when somebody has a lot of patella instability, where they'll go in and they'll just kind of cut this tissue to free up and try to minimize the pull of the patella, pulling out lateral, leading to kind of recurrent instability. That's my suspicion for what they are talking about. Nice. Awesome. Top bodybuilders. How healthy, unhealthy is that sport? Sweet. Past your MRI boards. Awesome. Fantastic. Love it. Congratulations. Top bodybuilders. How unhealthy is that sport for the athletes? Yeah, man. Let's look at... So, fun story. Let's pull something up here. I don't think it's healthy. Like, just long story short, I do not think that putting that much stress on your body is healthy. I don't. Like, you look at all the spine. I mean, goodness sakes, look at Ronnie Coleman. Appreciate it. Yeah, heal up. Good luck with your recovery. Look at like Ronnie Coleman limping around with all these back issues. Like, your body's not designed to do all this. So the recent, if any of you pay attention to this space, Derek Lunsford, is actually from the town I grew up in. It's from Terre Haute. He's been Mr. Olympia twice, I believe now. Nice guy. My wife knew him a little bit in college. But yeah, grew up in my hometown. It's been kind of crazy to see him go from small time Terre Haute, Indiana, shout out Rolls Holman, to being Mr. Olympia. Yeah, like I don't think it's healthy. Like, can I point to an exact research study? No, I'm not going to sit here and say I can, but like, you just look at all the issues that these guys have. I mean, all of the concern for like all the different supplements and like heart problems. Like, the human body does not naturally want to put on this much mass, right? I mean, it's not designed to do that. Like, but also the human body is not designed to play professional football. The human body is not designed to throw a baseball 100 miles an hour like we were talking about. So with every like elite level of sport, you are pushing the body beyond what it's designed to do. And because of money, because of like our own internal desire to push harder, we're all naturally wanting to continue pushing. Same with bodybuilding, right? Same with downhill skiing, Lindsey Vonn, right? Your body's not designed to fly down a hill on a pair of skis at 95 miles an hour. It's just not. And so all these athletes, bodybuilders, etc., like, you're pushing your body through crazy things to get to that extreme level of what you can do. But that doesn't mean your body wants to do that long term. And so, yes, there are always going to be long-term risks and side effects and issues from any of these sports. This isn't just a knock on bodybuilding now, right? This whole question of the natural versus the enhanced. Yeah, obviously, like, I'm not going to get into assumptions and like what some are doing, some are not doing. Not going to get into that, but obviously that's a whole other world, right? Of risks with stuff. So yeah, like, if my kid, I've got a son, and like, if he in 15 years says, hey dad, like, I really want to get into bodybuilding, I'm not going to like tell him no, but we're going to talk about doing things the safe way, the right way, and just what that could mean long term, right? Same gymnastics, any sport. You want to get into that sport, fantastic, great, super healthy, go work out, go lift weights, go exercise, go play sports. When you're pushing into that extreme, though, where you're pushing that body beyond what it wants to do, that's where things tip over and you're having a whole different like risk-benefit discussion. So Yeah, that's my thought on short term. Yeah, probably not bad, right? Long term, year after year, all that long term overuse on your body, strain on your back, strain on your organs. I mean, it's a lot. There's a reason that when we look back historically, humans didn't look like this, right? I mean, they were like shredded and strong, but they weren't like this. It's because that's not natural for the body. So, yep. Welcome. Thank you for joining and becoming a member. Let's see. Indiana, Kansas, Larry, Jersey too. Glad to see you. Yeah. Are you from Terre Haute? You Terre Hautian? Terre Haute's not bad. So Terre Haute, Indiana State, Rose-Hulman, Indiana State, home of Larry Bird. Well, not home of Larry Bird. He's from French Lick, but went to college in Indiana State. Terre Haute's not terrible. I went to Rose-Hulman. My wife went to ISU. My parents' family are still over there in Terre Haute. It's not a bad place. It's all right. I didn't leave because I didn't like it. So, that retinaculum you're talking about. Patella fracture, femur. Yeah, okay. So this is like a major traumatic injury. They might have been talking about something else. Retinaculum. I'd have to know specifically where, kind of what side of the knee and such. All right, let's go dive into some of our questions here. Born in Union Hospital. Yeah. Parents went to ISU. Yeah, I did med school at IU. I did my medical school. I was in Terre Haute for the first 2 years because they had a campus at Indiana State. What was the name of the hall? I can't remember the name of the building. So I did my first 2 years in Terre Haute of med school with IU, and then was up in Indianapolis for my third and fourth year for medical school. So awesome time for the football team. Yeah, that was great. Let's see. The Giannis injury, I believe it was the same one. But he bounced back super fast, right? He's been through a severe looking hyperextension, and he came back in 10 days. So I don't think there's any reason to be worried about Giannis's knee hyperextension. It didn't look nearly as severe as the one before. So swinging a bat in baseball, freak accident. Oh, the knee injury, yeah, crazy. So yeah, I think the Giannis one was from before. All right, let's pull up. Let's pull up our questions here and run through some of these. All right, how do I maintain update on new evidence and treatment guidelines in sports medicine? Do you learn as you go, or do you dedicate time to reading new evidence? I don't dedicate specific time. I have a couple conferences. There's one conference in particular that I love going to every year. It's the Advanced Team Physician course. It's held, it's always in December, and they hold it at different cities around the U.S., and they try to get the local medical staff, sports medicine staff, to come and give lectures. And it's intended to be about hey, what do we do for athletes in particular? What else do I do? A lot of stuff is just from social media. I'll follow a lot of different sports med docs on X, and they will share articles. I'll read those. I'll admit, this has been harder than I thought it would be. I don't do as good of a job doing this as I did back in fellowship, and a lot of it is because of journal access. When you're in fellowship or medical school, it's really easy to just get free medical journals to whatever you want. And there were some great apps, QX, Read MD, I think was the name of it, that I would go through, and you could log in, put in all your journals you wanted to follow. There were, some great sports med journals, and then you could just check the app and it would give you the summaries. Now you've got to pay for all those individual journals, and it just, the motivation isn't quite there. So it's funny because in training, you're you want to read all about the literature, and then in practice, you're using your experience. And I'll often go to the literature if I have a specific case. If I have a case, something's not going right, I don't really know what to do different, then I'll start reviewing more of the literature as opposed to just scanning through a journal every day. That's just my style. How to fix your collapsing ankle arch contributing to your shin splints? It might be. I don't have a quick fix for you. Posterior tibialis tendon. Look up some stuff about the posterior tibialis tendon. That's a main tendon for helping to stabilize the arch. And sometimes that can be playing a role in why people have a collapsing arch. But there can be other bigger deal injuries. So check that out. Let's see. I looked for this one. I could not find anything about this. Let's see. Soccer. Yeah, football. The Mexican goalkeeper tore his Achilles. Wondering how common is this injury? How does it impact the player long term? Let's see if we got a new. This is a good point. I've thought about if there was a way to get like CME credit. Like if there was a way to get CME credit for people, like continuing medical education or continuing ed credit for people watching my videos. I mean, like I know they're helpful. I don't think that highly of my own stuff, but maybe I think it's helpful, right? They're case reviews. Probably would be for more the level of like athletic trainers would probably be what I would think about. Yeah, it is sometimes interesting to go back and watch and be like, what was I thinking? Yeah, it's funny. Appreciate though that you learn a lot from them. Ever leave an appointment and be like, what the hell was that? Yeah, I do. I think there's this misconception that like we walk into a room and like, so here's a scenario. Like someone's coming to see you and sometimes it's simple, right? They broke a bone, they strained a tendon, they fell off, hurt their knee, they tore their ACL, tore their rotator cuff. Sometimes it's very clear. It's very straight. Like you hear the story, you look at the x-ray, the imaging, you take 2 minutes to do an exam and it's obvious. Easy. That's the majority of the day. The other stuff though, like you might have someone come in, you got a 20-minute appointment in clinic, and this person's had like 10 years of complex butt pain, right? Like hip butt pain, 10 years. They've seen 10 different doctors. They've had 5 MRIs. They've done 10 different treatments. They've been told 15 different things. They've tried all this different stuff. Like, and you've got 20 minutes to like try to like sit there and spur the moment, like take a history, do an exam, try to come up with a treatment plan. Yeah, it can be tough. And so you have to, in those cases, you have to kind of back out and be like, okay, what's the stuff I'm most worried about, and kind of go backwards from worst stuff to simplest stuff, like rule out the big, bad, scary stuff. Think, okay, like what other data do I need? What imaging's been done? What blood work needs done? Kind of look at those general categories of like blood work, nerve tests, imaging, labs, I said, what more data could help you? And then like trying some things. I use a lot of diagnostic injections in my practice where I take ultrasound, put numbing medicine in various tissues and structures to try to like rule in or rule out spots for pain. But yeah, there's definitely stuff where like the pattern doesn't make sense. Like pain isn't really localized to one structure. A lot of like musculoskeletal sports medicine is kind of pattern recognition of like, where do people hurt? What's the most common way that presents, like hip arthritis? What's the most common way people are going to tell you about their hip arthritis and your exam is going to suggest hip arthritis? But sometimes, absolutely, you walk out of the room and you're just like, I have no idea, like, what's going on. I mean, you kind of have an idea, but you don't have like a set firm. And so you work through your workup, right? That's why you do more tests. That's why you get more information. I mean, but that's okay. Like it's okay if your doctor doesn't know right away. That's why they get more information. They run through the differential. They run through the workup. They do a workup to figure out what's wrong. So yeah, this happens. Not all the time. Maybe a couple times a month, once a month or something. What were we looking at? Oh, we were looking over here at. Let's see. We were looking over here at our. Yeah, here we go. Zoom in a little bit so we can see this better. Yeah, so this was goalkeeper, was supposed to be Mexico's starting goalkeeper, I believe, for the upcoming World Cup. Let's switch back here. And yeah, tore his Achilles. To answer the question put on the stream, I mean, it's kind of interesting how you can see here how he looks back, right? So as he's taken off, you kind of see him make this little like look backwards behind him, right? Because that's what people will usually describe as like, oh, someone kicked me, right? It feels like someone kicked him. And so he looks back, yeah, and unfortunately, right there as he pushed off, unfortunately tore his Achilles. So to answer the question that was put over on the community page, Yeah, I mean, super common. Like an Achilles injury is going to be a pretty common injury in sports. Shouldn't honestly affect him long term, right? It's going to be a 9-month on average, 9-month to a year absence. Should not affect him long term. How did Tatum come back so quick? Man, this narrative will not die. He didn't come back that quick. Like he came back a little bit ahead of schedule, but not like crazy quick. Like he's within the range of what's okay. I mean, just everybody's like, oh gosh, he came back so fast. He's Superman. No, like go look at Tom Haberstroh on X. He made a really nice chart. I think the data was from Jeff Stotts in Street Clothes. Like, yes, it was faster than average, but it wasn't like months faster than average. It was like weeks, few weeks faster than average. So it wasn't crazy. It just feels crazy because he's back the next season. And most of the time when an injury occurs, because of where the season falls, you're going to have a seemingly longer absence because it just doesn't make sense to come back with like a month in the season. So he didn't come back that quick. Pet peeve you can be blunt with when working with patients. You're not listening to my advice. Don't lie because you know you're lying, anything like that. I wish people would understand two things. This is a good question. Number one, like that obesity and the rest of your thing, like health, like smoking, diabetes, those don't just influence how likely you are to have pain and have musculoskeletal problems, but they influence what we can do to treat it. So all the time, like I see patients in clinic who are, usually they're younger, they're like 40s, 50s, terrible knee arthritis. I mean, they've got terrible like advanced end stage knee arthritis, hip arthritis. They've tried injections, they've tried medications, they can't tolerate medications. They've tried to do some physical therapy. They've tried everything like to help their pain. Nothing has worked. The appropriate next step in those cases is often like a knee replacement surgery. Great surgery, goes very well the vast majority of the time, but you have to be below a certain body weight for the average orthopedic surgeon in your community to do a knee replacement on you. And so if you're, 100 pounds overweight, your BMI, most like 40 is a common cutoff for BMI. If your BMI is 50, like you might have to lose 100 pounds like before a surgeon will operate on you. And so there's a lot of times people come to see me and I'm just like, I can't do anything for you. I can't. You've been through everything. You've tried all the medicines. You've tried all the shots. You've done all the conservative things that I can offer you as a conservative sports medicine doctor. The only thing left is all that lifestyle stuff, which is really hard. And like, I'm not equipped to manage. Like, I'm not equipped to turn around somebody's obesity and tobacco use and horribly controlled diabetes and hypertension and cholesterol. Like, this problem has been developing for decades in the background. And like now the knee pain finally got to a point where people are really frustrated by it. But that's been developing for like years. Like this is a multi-year, decades long issue that's been developing in the background, and people want a quick fix. They want to come in and they want you to do something that's going to make their pain go away and like fix them, heal them. And like trying to communicate that this is a lifestyle problem that's been slowly developing and like is going to be really hard to turn around. That's really hard to do in a short appointment in a way that people don't get offended by. Because people hear like, oh, everybody's been telling them they're overweight. And they gotta lose weight. You gotta lose weight. Like people hear that and they instantly like react and want to turn off and not listen anymore. And so like that's really hard to be blunt, but also do it in a graceful way to try and figure out like, well, what have you done for weight loss management? Like, have you been to a weight loss clinic? Have you talked to your primary doctor about medications? Like, we've got a dietitian you can see. We can get you in with a PT to work on an exercise program. Like, you got to try and offer all these things and try to get them to accept like where they are and realize that this is like turning around a cruise ship. Like, this isn't just like, well, we're going to flip back and turn our jet ski the other way. This is like turning around the Titanic to undo all those lifestyle changes. And it's really hard. It's something I don't think I was fairly exposed to in my training. Depending on where you work, that might not be a problem. Like you might work in a very affluent, wealthy community where everybody's fit and healthy and in shape and like eats great meals and organic foods and exercises, and it's like not a problem and it's easy. I live and work in a place where that's not the case, where there's like quite a few like lower socioeconomic folks, and like they don't have those resources. They don't have the education to understand all that. It's so much harder, and trying to get through to that with people is really tough. It's really, really hard when someone comes in and it's just like, my knee hurts. I don't want my knee to hurt. I'm like, well, your knee hurts because of 20 years of what you've been doing with life. And like, I can try some things to maybe help your knee hurt less, but like until you turn this around, you're not going to get better. So people focus on like, you need to lose weight because it'll make your joints feel better. Well, yeah, but like you also need to lose weight so that you can get the treatments that we might do, because all the time, like I have people like see, and I'm like, I can't do anything else for you. Like there is nothing, medicines, shots, whatever. There's nothing else that I can do for them. And it's really frustrating. It's really frustrating. They leave upset, disappointed. So trying to communicate that. That was a very long answer. That was probably more than anybody is interested in. Yeah, and also like the therapy stuff. Like people, if I send somebody to physical therapy, like I want to know if they did it or not. Like I want to know, like a lot of people might be like, yeah, I went. And like in reality, they went one time. And so like if I'm confused about like, why didn't something work? Like, why aren't you getting better? I can't figure out why you're not getting better if you're not honest about what you're doing or not doing. So, yeah, good question. Was not expecting that. This is a really good question that I loved. The F1 Aston Martin driver struggling with numbness and possible nerve damage in their hands due to extreme vibration. Any thoughts? Yes, I have thoughts. Let's talk about this. So my thoughts are as it relates to carpal tunnel syndrome. So carpal tunnel syndrome, if we look here at the palm side of the wrist. So the median nerve, big long nerve that runs through the palm, goes through an area called the carpal tunnel on this side of the wrist, goes through that tunnel. That carpal tunnel is filled with the flexor tendons that wiggle and move your fingers. And so with carpal tunnel syndrome, the transverse carpal ligament that goes across the top of that carpal tunnel can compress. The nerve can get swollen, compresses on that nerve, pinches on the nerve. That median nerve provides sensation to primarily these three fingers, and also motor strength in the hand. And so early symptoms of carpal tunnel syndrome, numbness, tingling. As it progresses, you get weakness in the hand, true weakness. There are very clear associations with vibration and increased carpal tunnel syndrome. So like jackhammer operators. Jackhammer operators is like one of the most heavily associated occupational hazards for developing carpal tunnel syndrome because of the vibrations. So 100%. It's not that like, I don't think it's like the digital nerves in the fingers. So you've got skinny little digital nerves that go along the side of the fingers. I don't think it's so much like those are getting damaged. I'd be far more worried about carpal tunnel syndrome. And so absolutely, like if I was a race car driver and like I couldn't grab the steering wheel because of the vibrations, I'd be mad. I mean, that's like a true workplace hazard that is going to, in time, can absolutely lead to carpal tunnel syndrome. Now, like carpal tunnel syndrome is pretty easy to manage and like surgery is pretty straightforward, but like you don't want to be having to go through carpal tunnel surgery and management because the car you're trying to drive is giving it to you. I mean, they're like, yeah, that's a mess. So that was a great question. I really like that question. Talking about the Aston Martin drivers. Let me mention this. These GLP-1s have been a game changer. Yeah, I have no problem with these. I am like, put your pride aside and get on a medicine that's going to help you lose weight. I don't care. Like everybody that's like, oh, you need to like be tough and like just work harder and lose weight. BS. Like you have clearly not been around people that are struggling to lose weight and seeing all the implications of it. You have not spent time in your average middle America emergency department. Like these people who are hating on GLPs have clearly never spent time in the true healthcare setting of America. Because if you did, you would be shocked at how much of a problem obesity is. And so now, like, and I know there's like always going to be side effects of stuff the more of it you do. So we'll see what all that ends up being. But like everything I've seen and the little bit that I follow, I have no judgment whatsoever. No judgment if people are on these medications. Like, do whatever you need to do to get the weight off. Appreciate it. Yeah, we're going a little bit deeper. We're going a little bit deeper on things. But this is why I want to do these, is to have more of these, non-scripted, not that I script my, but like just more off the cuff conversations and talk about stuff. It's great. Check out Dylan Larkin's leg injury versus Florida. Yeah, let's see. We've got this saved in here. I think that this was an MCL. Sounds like he's going to be out for a couple of weeks and then be reevaluated. That would fit with an MCL injury. So if we look at that here, let's take a peek. Yeah, so look at how his right knee just buckles in right there. So kind of just gets balance, gets thrown off a little bit, puts that skate out, and then kind of right there. That knee just buckles inward. This is kind of like Sidney Crosby's injury in the Olympics. This looks like an MCL, hopefully low enough grade that he can be back in the next few weeks. So not too bad. Let's see. I'll address the Austin Matthews thing. Yeah, so I was kind of wrong with Austin Matthews. I mentioned like maybe a little MCL sprain. I was wrong about the severity, and I think I flat out like wasn't realizing how much time is left in the season or how little time is left in the season. It's the problem when I don't follow the sport as much as like basketball and football. I thought like worst case it's a 2-3 week injury, not like season ending, but then I realized like where we are in the season and that the Maple Leafs are terrible, and so it makes sense that they're not gonna push and chance things. So yeah, I thought it was just gonna be more of a contusion. I didn't think there was gonna be enough stretch on the MCL to cause a major injury, but it could have just even been something they're like, there's no sense in him pushing back, and so let's make it sound worse than it is, to be honest. So this last one here, we're gonna go maybe about 5 or so minutes left. So let's kind of get in those last bits of questions here. Why do some people tear or hurt something and writhe around in pain on the ground, but others walk it off, not even notice? Just everybody's different. I don't have a black and white answer. I don't think anybody has a black and white answer for it. People just process pain differently. Like there's a lot of chronic conditions like fibromyalgia. If you think about one end of the extreme where we know that there's like real changes in the brain of how people process pain. So things that your body would typically not be annoyed by, like a little stimulus that, like no big deal, brush it off. These chronic pain conditions like fibromyalgia, your amplifier is like cranked up really high to where you perceive it as way more painful and uncomfortable than it is, right? Because pain is in your brain. You're not like feeling the pain in your hand. Like you break something or injure something in your hand, and then the nerves are sending those signals back up to your brain, and then your brain is the computer that interprets, okay, what does all that mean? Like, how bad is it? And so you can absolutely have just like differences in your brain wiring, the way you perceive pain or don't perceive pain. There truly is, I think, something to like toughness, right? That's not like a volitional by choice, but definitely influences how people respond to and feel certain things. Has anybody been? I was just checking X here real quick. Boy, causing all kinds of drama with old Paul Saladino and his Eat Lineage bars. I don't have a problem with the bars themselves. I don't know if anybody saw this from my social media stuff. I don't have a problem with the bar itself. Like it looks like a good quality, like well-sourced ingredients, good macros. Great. No problem. My problem is just like with the messaging, right? I mean, I don't think it's any mystery that Paul has been, in my opinion, like just using fear to become famous, like scaring people, like, oh my gosh, like you're going to die if you eat seed oils. I just don't like that marketing tactic. I feel like that's how he became famous and developed his brand. And to now turn around and be like, well, it's okay if you don't eat Whole Foods as long as it's my bar. It just feels disingenuous. I don't remember ever like seeing him advocate for any sort of like protein bar before this. So that's what that was all about. If anybody's following over on X and seen any of that, yeah, the bars itself, like sure, go eat it. I personally am not going to spend $4 on a protein bar. I'm not like Quest. I like Quest bars. All the David bar controversy's been, I think, maybe a little bit overblown. But like, it's all marketing. Like, any protein bar is not going to be as good as Whole Food. There are like garbage ones. Most of them are pretty good, and everything else in the middle is just marketing. So go for it. Nothing against them. All right. Anything else? Any other last minute questions here? I don't know anything about Misty Copeland and dancing so soon after hip replacement. Sorry. I saw that question and I don't have any comment on it. Sorry. Yeah, I mean, that's kind of how I feel too. I also I kind of talked about this with, who was it? Oh, Eric, the chiropractor that was talking about don't drink water in the morning because you'll dehydrate yourself. Like, people who use their doctor label to get the benefit of the doctor label without actually like doing what the doctor label was for. Like, Paul, I'm pretty sure Paul is like a psychiatrist by training. So like, nothing against, I mean, like, if he independent research, great, go for it. But like, to then use your doctor label as like, look at me, I'm an authority because I'm a doctor. Sure, but like, you're not actually currently a doctor. Like, you have a medical degree, but like, if you're not actually like working regularly as a doctor, it feels a little bit wrong to like be referring to yourself as like, I'm a doctor, look at my authority in medical stuff, right? So he probably knows more about nutrition than I do. I'm not going to doubt that, but that kind of rubs me the wrong way. Let's see. Yeah, Berg's a chiropractor, right? Same thing. Like, he's like Dr. Eric Berg, and like, people see that and assume he's a medical doctor. He's not. He's a chiropractor. That doesn't mean he doesn't know about nutrition, but like, I guarantee it's intentional. Like, he knows that saying Dr. Eric Berg with no DC afterwards gets more clicks. People see, oh, this is a doctor telling me about nutrition. They must be smart. He might know what he's talking about, but it's like, there needs to be you should be required to put your actual licensing or credentials after your title, in my opinion. Too much bad misinformation out there. Thank you. That is a very generous super chat. Levin the office hours. Thank you very much. Speaking of racing and how passionate you are about CTE, do you know if there's been any correlation in head vibrations and car wrecks? Interesting. No, I don't. That would be a great question for Chris Nowinski on X. I'll find him and let's see. I'm not aware of anything. It's a good thought to have, though. I can't imagine that it's significant enough. I would think that just like car vibrations are going to get dissipated by your CSF, by the skull. I would be very surprised if there's enough like G-force coming in to make any difference with this. That's a really good thought. Thank you for prompting some thought. So this guy, Chris Nowinski. So yeah, he's like the big dog with all this CTE advocacy and everything like that. If you're on X, maybe shoot that message to him. He's genuinely pretty good about responding to stuff. So I wouldn't think so. I think too, if there was, we'd probably have heard about it more, right? Like, football is old enough that we've kind of hit the point, right, where we're seeing all the outcomes of CTE. I don't feel like combat sports, like MMA, is old enough that we're seeing combat, like boxing. Yeah, like we're starting to see that. I don't feel like MMA, we're seeing it yet because I don't think it's old enough for that. NASCAR car racing is old enough that I would think if there were going to be major effects from it, we would be seeing it by now. And I don't really remember hearing about any of it or seeing any of it. So that's another thing that makes me feel better about it. So yeah, absolutely. Appreciate it. Appreciate it. Okay. Anything else? Going once. Going twice. Let me refresh the community page since I said people could go put comments over there. Go check again. Looks like there's nothing else over there. Think about being a PT. No, I did not. My sister's a physical therapist, and I just, at the time, like, direct access wasn't really a thing, so PTs didn't have as much ability to, like, diagnose and kind of, like, work patients up and stuff. And so I wanted to do more hands-on stuff. I want to be doing procedures. I originally, when I started medical school, I thought I was going to do orthopedic surgery, right? And so my goal was orthopedic surgery, which is obviously very different than physical therapy. But I mean, great, like, good field. I think people who are going into physical therapy nowadays have to have a little bit of a real reflection for themselves of, like, what you're actually going to be doing as a physical therapist, because it's kind of like my job in sports medicine. Like, I would love to be all day long doing nothing but taking care of athletes. But the reality is, like, 90% of most sports medicine doctors' jobs in the community is just, like, taking care of elderly folks with arthritis and, like, ankle sprains. And for a lot of physical therapists, people don't generally like going to physical therapy, right? It's pretty rare in most communities to have a patient who's like, yes, physical therapy. Like, I'm excited. And so that can be discouraging when people are coming to see you only because they are being told they have to do it by their insurance provider before they can get an MRI or something like that. That can be discouraging. Now, there's a lot of different areas of physical therapy, right? There's, neuro PT, so neurologic physical therapy, where you're helping people recover from brain injuries, strokes, spinal cord injuries. There's amputee prosthetics. There's more sports orthopedics. There's pediatric physical therapies. There's a lot of, like, other areas in physical therapy than just general ortho that can be maybe different. But yeah, not what I wanted to get into. Not the world I wanted to get into. Okay, that's all I got. An hour. Man, these go by fast. Good one today. Enjoyed it. A lot of good stuff to talk about. Thanks for getting into some of the more obscure, like, clinic challenges and things I wish people knew different and whatnot. So appreciate that. All right. Appreciate all of you. Thanks for being here. Same time, same place next week. Everybody have a good week.